I'm Alex. I'm one of the ED doctors. I work with Dr. Sharma in the Department of Emergency Medicine, and a lot of other great innovators, and I'm really thrilled to have the opportunity to speak with you guys today. You know, just following up with what Dr. Sharma said, you know, I've had the chance to speak with a lot of different groups of individuals, types of folks in the last 2 weeks, just so happened to be that way. I spoke to Cornell informatics students. I went to Cornell Tech and spoke to engineers there. I went to NYP Queens and gave a grand rounds to doctors there. And the unifying message that I have for them, and I have for you guys as well, is that it is really important for us all to be able to have a conversation in the same room and to understand what each one of us do, because unilaterally we can't really redefine healthcare, but together we can definitely do a better job and have more chance of success. So my talk is Redefining Care, Hospital at Home and the Future of Healthcare Delivery. And I'm going to talk to you guys about 3 things here. We're going to just talk a little bit about why I think it's time for our healthcare system to evolve. We're going to talk a little bit about the value proposition for hospital at home, which is one of those models that can lead to that redefining. And we can discuss how AI can enhance hospital at home models, because no talk is complete without AI in 2025. So before we delve into talking about solutions, right, let's define the problem. Healthcare in the US is really kind of coming full circle now, right? So before the 19th century, a lot of healthcare was done at home. Give me a second. Yeah, wherever you like. All right, can you guys hear me? Okay, yeah, so a lot of healthcare was in the home time before the 19th century, right? And it was really only for the poorer folks that people went to the hospital, right? Most other people received care at home because that was the thing to do, bring the doctor, the nurse, anybody else to you as opposed to you going to them. That started shifting kind of in the 19th century, right? So we started having hospitals. The nursing profession really became more professionalized and developed. And so what happened is people said, look, actually better things happen when we're in a confined and unified space. And that really continued through the 19th century and then the early 20th century when we developed academic medical centers. And those became kind of the place where all innovation happened, the best medications were available, the best outcomes happened. And so that was the same for about 50, 100, 125 years. But what we've realized in the last few years is maybe the paradigm is shifting. We know healthcare is exceedingly expensive, right? In 2021, I think we spent more than $1 trillion in healthcare. I think that number has probably gone up significantly since then. We also know there's nosocomial infections, poor outcomes. Look, we know, right, by data that our healthcare outcomes are actually significantly worse than a lot of other countries, whether that developed or in the middle of their development phases. So we may not be doing things right. And so, now it's maybe time to think about a different lever. The other thing that's happening in our healthcare system is that the current system doesn't match the current or the future demands, right? So we know there's not enough doctors. There's going to be maybe 20 to 40,000 fewer physicians in primary care by 2036 than we expected, and the specialty fields are also going to be lacking. So we know that's happening. And the other thing that's going on actively now is that a lot of folks are leaving medicine. A lot of clinicians are leaving medicine, and that's because of some of the things that predecessors here have talked about. But burnout is an all-time high. Specialties like emergency medicine particularly suffer from this. And so if you look and you survey the doctors out there, about 1/3 of clinicians nationally may want to leave medicine soon, and it's not just the folks that are retiring. So we have very expensive, not enough doctors, and we also have this trifecta of an aging population, right? So by 2034, it's going to be the first time where older folks are going to outnumber younger folks in the United States. And this heat map here is going to demonstrate how many people are over 65 in counties. And you could see in the middle of America, everyone is going to be very old. And so folks want to be able to receive care where they want it. And I argue that now we're kind of in this period where we can no longer define, the physical hospital, and care can no longer be defined by a location. We must be able to get care to wherever these patients want it. And it's because we're doing it, very expensively right now. There's not enough clinicians, and there's going to be too many patients to care for, right? So healthcare is evolving, right? Patients increasingly prefer to receive care at home. The hospital is no longer the default. And I think what's really changed in the last few years is that technology has allowed us to be able to do some of this now. And I know we spoke a little bit about virtual health, telehealth, but AI is really going to usher in this next generation of us being able to deliver care remotely. So, if the growing evidence exists that we need to consider alternatives, I posit that one such alternative is this hospital at home model, okay? So it's acute hospital care at home, or hospital at home more colloquially. And it's a program that's been around for a little while. This idea of going to the home, again, existed hundreds and hundreds of years ago, and in even more rural communities across America, it's still going on in one way or another, right? But in 2020, CMS decided to push on some of the levers associated with the COVID pandemic and really kind of supercharge this process. And they allowed a waiver. So before, to be able to bill for Medicare and take care of Medicare patients, you had to be at a site, the patient had to be at a physical site that a nurse could respond to the patient immediately. A nurse had to be on site 24/7. And that was really the only way you can say, the patient's hospitalized and they can care for the patient and we can bill for the patient. But in 2020, as part of the public health emergency, Medicare broke down a lot of those barriers. And they also broke down a lot of barriers around reimbursement. They said, we're gonna pay you the same amount of dollars that you would get for taking care of a patient in the brick and mortar setting as if, and if they're at home. And so a lot of programs nationally decided to take the plunge. And to date, about 300 hospitals have applied for the waiver, which allows them to care for patients at home. And NYP is going through that process right now. There's about hospital programs across 38 states. Some of them see just one patient, two patients, but some of them are seeing hundreds of patients a week. And nationally, I think we've seen over 35,000 patients at this point with hospital at home. So why does a hospital at home make sense? There's a lot of different levers, right? So there's capacity creation, there's financial viability, improved patient experience, quality and patient safety, and capacity building. And so what we're able to do with hospital at home is actually create more physical beds without having to build infrastructure in the traditional sense. We think that an average bed, I think it's $1 million to build a hospital bed on average, including everything else that goes into it. In New York, obviously, that number is much more expensive. So maybe billion, is that right? Yeah, so it's very expensive. But this allows us to create capacity in a way we haven't been able to do before. We also know that we can improve patient experience because nationally, hospital at home patients really enjoy the experience. There's also better clinical outcomes, so decreased rates of mortality when they're at home, decreased delirium, less hospital-acquired infections. And so patients also happen to get readmitted to the hospital with less frequency, which is all a good thing. And for a health system, it's great because it also builds capacity. If you can take care of something that's complex, so an acute hospitalization in the home, well, then you can do a lot of other things remotely as well. You can do hospice at home, subacute rehab at home. You can do a lot of episodic primary care maybe at home as well. So being able to build a chassis of technology and the infrastructure of healthcare providers that can deliver care in the home is really a good thing for a health system to build. And so that's why so many have decided to do that, and we have as well. So hospital at home is really acute inpatient level care. It's an inpatient admission to the hospital. Someone comes with heart failure exacerbation or a COPD exacerbation, and you feel like they need to be admitted to the hospital for a few days. Traditionally, they go upstairs, or really now in New York and across the country, they wait in the emergency department for 3 days, and then maybe go upstairs, or maybe they're discharged. Now we can send these folks to their house and actually provide much better acute care in the home. And so we do that by leveraging technology and then multiple daily visits by care members, so nurses. But a lot of the other things, so monitoring their vital signs, telehealth encounters with providers, so PAs, MDs, nutritionists, PT, OT, all of that is done remotely and in their home. So it's really great. And it's not a lower level of care or a different level of care. It's really acute care. So the same people I would usually admit and subject to 3 days in the emergency department, waiting to get a bed, I can now send them home. So there's a lot of programs out there that have been successful. I'm just going to share this slide quickly, but some of the programs nationally are taking 50, 60 patients home at a time like this. MGB, I think, wants to do 20% of their total inpatient volume remote in the hospital at home environment now by the next 5 years. So this is a tremendous opportunity to expand capacity, meet the demands of our patients, and frankly, you can see more patients remotely. A physician can oversee a PA that can see 20, 30 patients at a time potentially in this manner, as long as the technology that's being utilized is smart and provides us enough accurate guidance to make decision making. So we can really build capacity for our health system and our general population by doing this. This is what an average day looks like for a patient in a hospital at home environment. So they come to the hospital, we decide that they need to be admitted. They speak with a PA or a care coordinator. We make sure they're the right patient, because you do need to make sure that it's the right patient. We get their consent, we get an ambulance, and we take them to their house. En route, they given a remote monitoring patch, so we can 24/7 get a sense of whatever vital signs we're interested in. Our program will start with blood pressure, heart rate, respiratory rate, temperature, and O2. But there's a lot of other things you can do with wearables nowadays, as you guys know better than me probably, including EKG, stroke volume outputs, you name it, you can probably do it now with a wearable. Some are better than others, but that's a different question. And so then when the patient is at home, they get their care. A nurse meets them at the house. They'll give them their IV medication. They'll see a doctor via telehealth, telemedicine. We'll continue the care plan. Overnight, they'll have access to us on video or audio 24/7. We'll be able to deliver medications to their house. We'll do x-rays, ultrasounds, echoes, EKGs in their home. And we'll take care of these folks. And nationally, like I mentioned to you guys, the outcomes are phenomenal. And the other important thing is this is a way to combat burnout, because providers love this. Nurses love this. Doctors love this. So it's a win-win for the health system as a whole. You can definitely retain more folks when they're happy at work. So this is how technology plays into effect, and I really like this. This is by Dr. Topol and Bruce Leff, who are kind of thought leaders in this field, and Dr. Leff specifically is probably the founder of Modern Hospital at Home in America. This talks a little bit about the journey of technology in hospital at home. And in the yellow are kind of levers that we still need to act on and challenges that we face as a health system when we're involving technology in the care of these patients. So we have really great data, and we can aggregate it and analyze it and help lead the clinical decisions. But there's still a lot of challenges around there about noise, accuracy of the data that we're receiving, multimodal dimensional data analysis, like some of you guys talked about. How do you incorporate visual, language, motion, movement into the decision-making of based on the patient. So I think we have a lot of work to do, but this is a really, really interesting opportunity. I see AI having a very, very substantial role in hospital at home in the future. And these are just some of the obvious, I think, kind of places where it can fit in, and in some places already fitting in. Predictive analytics, so identifying which patient is the right patient for us to take home, right? Not everybody makes sense, but the acuity and the types of diagnoses that can go home is actually surprising. So nationally, folks post-transplant go home on day 3, post-lung transplant, which I think is unheard of almost to folks that are hearing about this for the first time. But the outcomes, again, are great. A lot of oncology indications, right? Those patients that are in the hospital waiting to see if they get sick from their, while they're on their CAR T therapy, those folks can go home. And then you have more traditional things like post-surgical care, maybe your cholecystectomy that goes home a few days earlier, or maybe it's your COPD or pneumonia or cellulitis patient that goes home. So there's a lot of opportunity for AI to help us identify the right patient. Maybe it's something in their medical record that we're missing. Maybe it's their trajectory in past visits or past hospitalizations that we're not seeing clearly. We just don't have time for. So there's opportunity for that. Documentation, obviously, is also another place. We've talked a little bit about that, but it'd be great if we can get to a place where, physician in the loop certainly is important, but is not taking up more of our time as clinicians, which is part of the challenge, I think, for this kind of use case at this point. And then, using AI for remote monitoring devices. So making sure that the signals and the data that we're getting is more stronger and better with less kind of error and noise than what we have now. So I think that this really is the future, this personalization and this personalized care pathways for chronic conditions. I think that's really the potential of AI. So let's talk a little bit about a single patient, right? Let's talk about George. George is 68 years old. He spends most of his time, he's got heart failure and he's got diabetes. He spends a lot of time being admitted to the hospital, okay? He spends like 50% of the year being admitted to the hospital. And we have programs like our community paramedicine program that can help, and we can decrease his time in the hospital a little bit. But what if there was a care pathway that was designed specifically for George? So George comes to the ER. This is his third time to the emergency department this month. We don't know what to do with him. Sometimes he needs admission. Sometimes we admit him just because he got admitted last time. That's really kind of how things work. He's kind of borderline. But it'd be great if, AI could leverage a lot of that, experience from prior hospitalizations, prior visits, can dig deep into the EHR, and then can interact with some of the wearables that George may have. His daughter gave him an Apple Watch. He has an Oura Ring. Why can't we integrate all of that in our decision-making process, right? The future is not so far away. It's just nobody's figured out how to integrate everything in a compact way for us to be able to digest it when we're at the bedside, but it's coming. So then we decide, okay, maybe the signals say that we should admit George, right? But then AI can also help us figure out how acute this is. Maybe he needs a lot more intensity than I can offer at hospital at home. Or maybe hospital at home is perfect for him and he's gonna be really happy to not have to spend another day in the hospital. When he gets admitted to the hospital, let's say we think he's safe for hospital at home, AI can leverage and use some of those remote monitoring tools that we talked about to help us guide decisions. Maybe it's an understanding of, his creatinine trends up or down when I give him this much Lasix. Let's create a precision dose just for George, so that way we can actually identify how much he needs. I give everything in aliquots of 20, but maybe that's too much. Maybe that extra 10 milligrams actually kills his kidneys, and we don't want to do that, right? And prolongs his hospitalization. So that's an opportunity. And then we think about adherence, right? So George can talk to a chatbot or an agent, right, and figure out how to educate himself in the meantime. So he can remember, the AI can remind him to do medication adherence, which we already do. A lot of companies do that already, right? But it can also provide him education. I think that's really valuable while he's admitted to the hospital. More importantly, when he's discharged from the hospital, right, an AI can help coordinate his care and ensure that he doesn't bounce back to us. So that, that challenge of making an appointment is really a big deal and a pressure point for a lot of patients. We know that, I don't know if any of you guys have tried to make a primary care doctor's appointment. I did. It took me like 9 phone calls. I was told I was going to be called back. I never was. And then like 4 months later, I got an appointment, like 3 months from now. And if you have public insurance in New York, your chance of getting a neurology appointment is like 0. You're going to wait till next year, maybe you might as well go and get public insurance in a different state. It's really a challenge. So, this is not just a New York issue, it's a national issue, but using AI to be able to leverage something like this and help a patient like George is really the future of care. So AI sits at the continuum of care along every step in the patient journey, and it can certainly play an important role in caring for our patients at home. I'll leave my final thoughts with you guys. Healthcare must move beyond traditional hospital walls. I think it's happening already nationally, but it's more important to leverage technology to do so in a smart way. Hospital at home is scalable, effective, and it's a great model for the growing demands and the changing demands of our healthcare population. And I'll leave you guys with what I started, which is engage across party lines. Engage with your researchers, engage with your clinicians, your entrepreneurs, your business folks, your engineers, your operators. Getting a clinician at the earliest point of your innovation process is really critical. So I urge all of you guys to collaborate and work together, and I'm happy to answer any questions. Thank you.
Future of Care is New York City's premier community for healthcare innovation. To learn more, subscribe to our channel and visit our website at futureofcare.nyc.